morning, everyone. I hope you enjoyed the first day of the summit yesterday, and are even more excited about what's to come for today. This past year was filled with a lot of work. I would say it was a bit like a roller coaster, had its ups and downs, but now, like seeing so many people yesterday and today, being here at the summit, every second was worth it to put into this project. A few notes of housekeeping. The fire exits, as in the plane instructions, here and over here, and the summit volunteers who are available to help you with if you have any questions are the ones who are wearing a red lanyard. And then lastly, we have the rooms and buildings for a specific amount of time. So to help you to deliver with the maximum value, we'd be grateful if you would come back on time for the next panel to start. This summit is organized in collaboration between two student societies and the Future Impact Society, the Entrepreneur Society, and the Alumni Association London. And this collaboration between students and alumni has never been done before at LSE in such a large-scale manner. But I think this collaboration was very much needed, and I'm very proud that we made this happen for this summit. The panels are moderated by alumni and also by students. So for example, our next panel, Healthcare for Humanity, is moderated by Grace. She's in her final undergrad year. And for me personally, it's been a great pleasure to work with so many amazing alumni and also amazing students and create a close-knit community of like-minded people. I myself just completed my master's degree here at LSE. So technically, I'm an alumni now, but today I want to say a few words as a co-president of the summit and as a former student. Nowadays, access to information becomes easier and easier. For example, listening to podcasts on your way to work, watching YouTube videos, or even recorded lectures. I mean, we've all been there. So yet, in my opinion, having this access to information is simply not enough. This access to information becomes more passive because you listen to these podcasts, you listen to all these YouTube videos, but you don't get the chance to discuss and share your thoughts afterwards. And at the same time, the flow of information becomes unmanageable for a lot of us, which leads to an information overload. Creating platforms for open and critical discussion is needed to be challenged in our opinions and to discuss overarching topics that our whole society is faced with. Topics that sometimes are forgotten when exams are lurking around the corner, or work projects become stressful, or simply life gets into the way. We're living in a complex and fast-moving world, and we need to be able to adapt quickly to changes. Climate change, the current economic uncertainty, global healthcare needs, all require multidisciplinary and interconnected solutions. For that, a diversity of opinion is needed to break through the echo chambers we live in. Long story short, we need courageous initiatives like the Future Impact Summit to come together, to connect, to be challenged, to be inspired, to discuss, to learn, and most importantly, not shy away from complex topics where the solutions are not as straightforward. For this, we need academia and the private sector to come together at one table, or one panel, and discuss the most relevant issues in the near future. This is one essential part of the summit. The speakers we invited for this summit range from academics, startup founders, strategic policy advisors, or even best-selling authors. However, besides all these great speakers, all of us have an essential part in the summit. So please don't be a passive listener. Ask as many questions as possible. I loved seeing so many questions yesterday. And in my opinion, the most challenging questions were asked by the audience. So hopefully we can keep that up today. Talk to the people around you in the breaks and discuss the topics we were just listening to. One great thing about this summit is that alumni and students come together. Take this opportunity to be reminded of the time when you started studying and you had this eagerness of changing the world. Finally, no good welcome speech comes without saying thank you. So a huge thank you to everyone who's been part of this journey. Thank you to Abby from the Students' Union for helping coordinate this process and supporting us throughout it. Thank you, LJ Silverman, who was kindly arranged the LSE Generate for our food fair during lunchtime and connecting us with the great LSE food and beverage startups that will be served during lunch. Thank you, Dr. Erin Cheng, who was a professor while I was doing my master's degree. It's lovely to see you here. Thank you to our sponsors, Noddle, Alcom, and Kaya, Mesmerize for the VR experience, and the Barclay Foundation. And most importantly, I want to thank 3 people. I want to thank Ken for all the crazy hours you have put into making this reality, and especially for being the visionary of this summit, although that meant putting up with all your ideas and dreams. Also I want to thank Badi for your calmness and clear mind throughout this past year. I wish you all the best with FuseCube. And thank you, Alex O'Connor, who founded the Future Impact Society and together with Ken came up with the original idea of the Future Impact Summit. The Future Impact Society was founded a year ago, and since then they hosted like about 15 great events and has brought together an amazing community that engaged thoughtfully with ideas that will shape the future. So thank you very much. And now I think we can start into this day, and I'm very excited to hear the next panel.
Good morning, everybody. Welcome to the first panel of today, Healthcare for Humanity, Shifting Paradigms in Global Health Systems. I think we have perhaps the biggest job of any of the panels, of any of the themes here, covering the future of health for the entire globe in 1 hour and 15 minutes is a tall order. So the main theme of today is around proactive and preventative health measures and how we reach this attitude. We'll be exploring the role of health tech in innovation. We'll touch upon the future of state-run health and whether it's kind of compatible with this shift we're talking about. And we'll also explore some key areas of health tech, like genomics and how we use genomic data with socioeconomic data, things like this. So I think we'll start with brief introductions. My name is Grace. I'm a final year student at the LSE. Perhaps a little bit off the beaten track from a standard LSE undergraduate. I'm interested in epidemiology. I come from a family of nurses. I think that's how I became interested in health. Over to Maxine.
Perfect. Lovely to see you all. I woke up at 4 o'clock this morning to get a flight down from Edinburgh, and I arrived at 2 minutes to 10, so I'm sorry if I'm a wee bit flustered. And I was at 40th birthday last night, so I'm 98% champagne right now. So my name is Maxine. I run a programme at Genomics England called Diverse Data, which is all around how we improve the ancestral diversity of the data we have. I am an LSE alumni. I did the Health Policy Planning and Financing Masters in 2014, I think. And then after that, I did a Machine Learning and Electronic Health Record PhD. So my interest is very much around kind of where data and technology and machine learning intersect with health. And I also love a community and love a meetup, so I'm involved and started two. One is called One Health Tech, which looks to support diversity and inclusion in health innovation. And the other community is Data Science for Health Equity, which looks to bring people who have kind of technical talents in data science with people who have domain expertise in addressing health inequalities.
Okay, hi everyone, morning. My name is Yamasi. So I work for a biotech and genetics research company in Nigeria called 54Gene, but I'm a public health by profession, so kind of fell into biotechnology, so to speak. And really we're just trying to promote the African diaspora in terms of clinical research and also genomics as a whole. But aside from that, my interests are really promoting healthcare in developing resource-poor settings, improving healthcare infrastructure is really a big passion of mine. So thanks for having me.
Hi everyone, I am Brice Kitio. I am the founder of WeCare. WeCare is a venture that is operating in DRC and Cameroon in Central Africa, where we are empowering people to build enough saving to be able to access healthcare. And in terms of background, I am a pharmacist and health economist by training, trained in health economics here at the ASC. I am really interested about the use of tech to improve access to healthcare in low-income setting, because the problem that we are seeing, or what we study when we are in a big institution like here, we always talk about, okay, how healthcare is organized. In a developed economy, there is still a lot way to go in low-income setting in Africa and some other countries in the world. So very happy to be here with you today.
Thank you. I think I'd like to start just firstly with a broad definition of what proactive and preventative healthcare means and why we should be striving for it. Maybe Maxine, I'll start with you on this one.
This is a really tricky one, I think, because in some respects, like perfect health doesn't really exist. All of us will right now have, an aches and pain, a hangover, a sore ankle, whatever it might be. And so for me, proactive and preventative health is making small steps, small decisions, small changes that ultimately end up and kind of gun towards a better health. But I would say it's like not the absence of any ailment, because I think that if we all lived our lives without that, then we probably wouldn't be able to know what being kind of healthy feels like. That would be my definition.
And I think just as a brief introduction question to Yemizi and Bruce, what does innovation mean to you, and what role will health tech play in innovation? So Yemizi.
Okay,
that's a big question.
Yeah, that is a big question. Well, so for me, especially in the context of proactive and preventive healthcare, innovation, not only are we talking technology, which is what excites everybody right now, but also like adaptability as well. So if we're talking, especially, Bryce and I from resource poor settings, something that you would think an innovation in tech, we're a little bit staggered behind, right? And then also healthcare behavior plays a massive impact on that. And also how people approach innovation, how people welcome it, and things like that. So for me, it's really about adaptability. I think that's the most important thing.
Bryce?
Yeah, I think it is really a tricky, innovation is really a tricky question in healthcare. I think that when you use the word innovation, a lot of people think about tech, so application, MRI, which is great. So I think that, yes, this solution can help to scale some of the challenge that we have today. For example, scale the delivery of behavioral change management. So we have some example in diseases like diabetes, hypertension, where tech can help to improve the behavioral part of it to reduce the risk to experience catastrophic event like cardiovascular disease. But in the setting where I'm operating, innovation is more around organization, operating model. And something that I really like innovation in this setting is task shifting, which is we are able to identify some tasks that are done by highly trained health professionals and give that task to people who are not highly trained health professionals. And one example that I want to share here is an organization called Mother to Mother that is operating in South Africa. They are focusing on preventing the risk of transmission of HIV between pregnant women and their child. And what this organization is doing is that they train mothers who are living with HIV to educate other mothers to be able to have basic education on the prevention, basic management of the disease so that they can reduce the risk. And through this model, they are able to impact the life of something like 50 million people now. So this is kind of innovation that I think can be really breakthrough in the future.
And on this topic area of increasing accessibility and affordability, what could you explain to us a bit more about what WeCare does?
Yeah, at WeCare we are operating in, as I said, we are operating in DSC, and our vision is to improve access to healthcare and help people to invest more in healthcare in Africa. What we are doing is that before answering the question about what we are doing, let's set the context about healthcare access, as affordability of care. Healthcare is something that is expensive. At any point, we need to think about, okay, who will pay? And in Africa, the penetration of insurance is very low. Less than 2% of people have insurance, meaning that the majority of people are paying out of pocket. So how these people, the consequence, it becomes that people delay access to healthcare, people postpone healthcare, and for those who are able to go to hospital, they experience catastrophic health spending, meaning that healthcare is something that is pushing them more into poverty. So what we are doing at WeCare is that we are trying to find a way to help people to save money, to be much more proactive in terms of thinking about the finance of their future healthcare. And it is difficult because, people don't want to save. But what we discover by spending time with them, people don't want to save, but people spend money every day. So what we do at WeCare is that what if we ask the question, what if it were possible to partner with the organization or the retailer where you go and spend your money and build some kind of loyalty program with them to be able to, each time when you spend money, you save a bit of that money for your healthcare. So that's what we are doing. So the first time is to make health saving passive, natural in your daily activities. So you are saving money for your healthcare, whatever, when you are spending money. And the second part of it, which is linkable of the question of behavioral science, some behavioral science result, is we are trying to add to make the experience enjoyable. So when people talk about healthcare, we are always bringing, oh, you need to save money because of the risk. So what we are trying to improve is to, in daily life, put some kind of gamification, challenge to help people to say that, oh, by the way, if I achieve my goal in terms of saving, I will win a bit of reward or something like that. So helping people to save naturally and also improve enjoyment on the action of saving for healthcare. So that's what we are trying to do.
I'd like to kind of look at this sort of behavioural aspect a bit closer, because it's clear, I think, across the globe that we need to make some individual behavioural changes, incentivize individual behavioural changes. I'm wondering, what are some of the biggest barriers that you've experienced to incentivizing people to save for a rainy day, I guess particularly those on a subsistence income?
Yeah, the biggest barrier is, at least for me, what I'm saying is education. So definitely saving for something like healthcare is something that is, it's not top of the mind of people saving for healthcare, really. Even here, healthcare is not top of your mind. So there is one study that was done by one professor here, Professor Ashraf, who is at the Marshall Institute. She has done one study where she was doing a commitment device, so empowering women to save. And it is interesting because one question that was asked, it is, okay, set your goals. So what was the most important goal that the most common use that people was putting was Christmas, birthday, partying, stuff like that. So healthcare was actually less than 0.5% people were putting healthcare as a potential goal, meaning that really healthcare is not something that is popping up as a priority for people. So education about the importance of saving for healthcare, education putting the idea of having money for rainy days is really something that is important. So in our platform, we have something that we call micro-learnings. So again, pushing all these micro-learnings about, okay, just the importance of healthcare. If you achieve your goal, you will be able to do this. People around you who are achieving their goal, this is what they are able to do with the money. So we are trying to bring all that to create this sense of community between people to be able to achieve the goal. But definitely education is really one of the key challenges.
And I guess on a broader question to the rest of you guys, how do you think we empower people to and incentivize people to look after their health? I mean, particularly in this country, Maxine, what's your view, what's your experience on how people interact with their health and where people stand, with looking after themselves?
Well, it's tricky. So I don't kind of work necessarily in like policy making now, but I am married to a GP, and so I do get the kind of it from both sides in some respects. the thing about, I think, preventative health is that you're fundamentally working on reducing risk for something that's got a very long latency, which is, I mean, most conditions accumulate over a number of years. And so you're kind of constantly working with the risk of future you that could be because you've had, an extra cheese sandwich with loads of butter now, or it could be because you cycle to work and you took a dangerous route. Both of those two things give you very, very different risk profiles for very, very different outcomes. And, in all of our daily lives, we're constantly saying, we should go for that run, or we should not have that extra glass of wine or whatever. But it's a kind of risk that we don't actually fully understand and fully know, and our genetics and our environment really change that. And so you've got this kind of soup of quite complex personal risk that an individual person has to kind of work with at any given point. And people have different preferences. Some people want to live fast, die young. Some people want to live long and healthy lives. People have different preferences about what they see as quality. And so I think if you are a clinician, you're a doctor, especially if you're a GP and you're sitting in front of a patient, my husband often says, like, what's the thing that matters to you the most? And let's kind of optimize for that. The site situation in the UK is obviously that we have a system that's free at the point of care. And so, we kind of have the situation of moral hazard, high use because you don't face a cost. But the things that we are facing a cost are the things that accumulate to our risk profile. So, for example, the food that we eat and buy, the gyms that we go to. But that does mean that a lot of the burden is therefore placed on the acute settings. So, we've now just seen health minister after health minister double down on hospitals, whilst we see the slashing of funding in public health, in social care, in education. And the slight problem with that at a systems level is that if you're constantly defunding all those areas that kind of sit in your social determinants of health, you're constantly going to see the impact of that manifesting in the prison system, in hospitals. And unless we start to kind of close that loop whereby we link that up and we lengthen the funding cycles for a lot of these services, i.e. so they're not linked to electoral cycles, which are 3 or 4 years or 1 year, depending on whether you've got a pandemic or not, then you're never going to be able to really put in place a sustainable system to incentivize proactive and preventative healthcare system at an individual level or at a system level.
It's interesting, this kind of idea of almost business cycle, like funding cycles. I guess in resource-constrained contexts, when we're talking about, I guess, areas where you guys have worked that are very dependent on foreign aid, do you think that, business cycle behaviour and international aid, is this really going to hamper our ability to have sustainable health outcomes and move towards proactive and preventative health in international development context?
Yeah, I think that's a really good point, actually. From my experience, prior to working where I am now, I've worked for NGOs and charities and things like that, especially with a lot of research on ground, so specifically targeting bottom of the pyramid. And one thing that I've realized is that a lot of this funding actually doesn't reach the population that they're intended to, right? So even if you're going to these areas and you have these wonderful innovations and things like that, you really, really have to start from the ground up. Even the type of language you're using, like if you come in and you start saying insurance, you even have to break that down, right? So you'll say, okay, imagine if everybody in the community that you're living in puts money in one pot. And then you have that increased access, that kind of thing. So that's how granular you have to start. And then, talking about non-communicable diseases, especially in Nigeria and other developing countries, we're kind of at a tandem at the moment, right? So you have like emergent diseases that are challenging us, especially like infectious diseases, malaria, and things like that, aside from all the things that you deal with poverty. And then we're having a shift towards people living with hypertension. Now it's more than 1 in 3 in Nigeria, diabetes and cancer. And when we're talking about healthcare infrastructure, the diagnosis is just, it doesn't really happen because people don't go to hospitals unless they have really emergent needs. And then I think if we're talking about public funding and things like that, the target should really be towards the data. So even if you're doing research and on touching on some of these diseases that I've mentioned, and you look at articles in Africa or research settings, they're probably made 5-10 years ago, which is just essentially an infinity when we're talking about technology right now. and look at the massive shift from COVID and things like that. So that is really what I'm like intrigued in and trying to build upon. Because the funding, unfortunately, just going back to what I'm saying, it doesn't reach the people that it's supposed to. And I think if you want to do that, you really have to penetrate from the community setting and then start from there.
I think this would be an interesting point to talk about the future of state-run healthcare, particularly across resource-constrained contexts versus somewhere like the UK. Maxine, does state-run healthcare, is it compatible with this idea of prevention? Is it a more systemic problem, or how does state-run healthcare look in the future, and how does it marry with prevention?
Gosh, that's a massive question. I think actually putting this as a US-UK comparison, I think probably illustrates a couple of axes that intersect here. So I would say in the US it is one of the most unequal health systems in the world, and in the UK is one of the most equal ones, whereas in the US it's by design a little bit more geared towards incentivizing prevention, and in the UK it's not. So those are kind of the axes at play here. I personally believe in mixed models. I don't believe that the way that the NHS is funded at the moment is at all sustainable. I think that's partly because of the individual responsibility that people take. In the UK, I don't know how many people are British here, but certainly it is effectively a religion. And that gives you kind of great loyalty and buy-in, but it doesn't necessarily incentivize you to be healthy. But it certainly gets you kind of emotional when you see things being cut, or nurses with masks or people sleeping in corridors, whatever it might be. But that hasn't at the moment translated to people actually behaving in any more preventative way. When I talk to kind of colleagues who work in health policy, or even individuals who are US based, coming from the health insurers, there is a much bigger push towards prevention. In part of people's health insurance plan, they're given so many more resources and tools and programs to follow, which are the kind of basic stuff around running and exercise and eating healthy and connecting with your friends. And we just don't have that. That really should be coming from, say, your GP, and it's just not, because they are really stemming the flood of people coming in with built up weeks or months of acute conditions and acute worries. So I think there's a kind of real tension here between like prevention and equity. I think as a country, for us, equity is quite synonymous with our health system, and prevention isn't. So I think that there's lots of models out there that are slightly more social health insurance based. I personally think that the Dutch model is quite compelling, and that's a mixed model whereby individuals can choose their insurers based on effectively hospital factors and quality, hotel factors and quality, whereas the risk pools for the different health insurers are adjusted by the state. So that means the incentive for health insurers to negatively select against individuals who are high risk, that risk is removed. So I think for me that balance is a good point at which the state intervenes to promote equity, but individual responsibility and choice is put on citizens to take a little bit more responsibility, and also to feel like they've been a little bit more involved in the selection and the delivery of their own care.
It's interesting. I know, Bruce, we were talking about this briefly before. Is there this idea that we've kind of prevention and proactive education is already been implemented in resource-constrained contexts because it's cheaper and because it's had to be, right? How does this look going forward?
Yeah, I won't say already, so we are trying. Because, as MSC was saying, definitely we are seeing a lot of, in the literature now, there is this question, this headline on double burden. So infectious disease and the growth of non-communicable disease in Africa. So I believe that with the improve of innovation, we can move to the kind of system that Maxine was describing, where people will be able to take more care of themselves, so they will be able to manage their disease from home. They will be able to have in their pocket the health coach, because in low-income setting compared to high-income setting, given the cost of care, we don't have prevention is in terms of cost of money, the value of money, it is the best thing for us. Meaning that if we need to convince a government or to be able to be part to this kind of program, we need to focus on prevention because, yes, the growing burden of non-communicable disease when you will really arrive in Africa or in low-income setting, let's say low-income setting, not just Africa, it will be very, very costly for people because we don't have all the infrastructure that you have here. So if someone had a heart attack here, we will have someone who will arrive in 15 minutes here. In most places in Africa, we don't have that. So if prevention is not the forefront, we will have some problem.
I'd like to kind of briefly touch upon the role of the health workforce in resource-constrained contexts. How do you think that the health workforce plays into this kind of future vision, and how do you think the workforce crisis varies across the globe? Maybe we'll start, Brice, with you.
Well, yeah, the question that is really important question, which is linked to my first point about this innovation, about task shifting. Definitely, this is a massive problem in a place like Africa. So when you look at the number of nurses, medical doctor per habitant is really, really low. So this has an important implication in terms of the management of patients. This has a important implication in terms of the cost because, that's why we need to have new model because let's say that we take the example of my country, Cameroon. So if we want to just say we want to match the model of number of healthcare or health professionals that we have in developed country, let's say UK, if you do the math, really it will take hundreds of years to a country like Cameroon to be able to achieve the same number of per habitant. So what we need is to really rethink the way that we will deliver healthcare in the future. Community health worker, task shifting, knowledgeable people who are able to understand, connect all these people with the highly qualified health professionals that we have in place to be able to deliver quality of care. So in terms of health force, it is really, really big problem. There's other problems in terms of brain that people that are leaving the country to go in Europe because of money, some stuff like that. But I really think that is one of the biggest challenges that we will have on the ground.
In terms of this kind of brain drain idea, of course, having spent and worked in Nigeria, what's the impact of this on the medical community that I guess you've experienced?
Yeah, exactly. That's what I was thinking right away when you asked that question. Brain drain, not only in Nigeria, which is a massive burden for the healthcare system, but we're even starting to experience that or have been experiencing that here with the NHS. I have a lot of friends who are doctors that are going to Australia for different reasons, but, bringing it back into the context of Nigerian, what that means is that first of all, even to go through medical school, right? It'll probably take the average person about 10 years due to strikes and things like that. So to have that qualified doctor, so to speak, with the educational infrastructure already broken down and you've already provided all that skill set, and then for them to leave the country is a massive problem. And then not only just talking about doctors, but healthcare professionals as a whole. Like I said, I work in the biotech industry, and that is just very, very limited in terms of people that we have that can qualify for those roles, talk less of nurses and things like that. So that is something that the government definitely has to focus on and figure out why people are leaving and stopping that situation from happening. But also secondly, talking about state run healthcare and things like that, what I've seen and the most exciting things that people are doing is really private, right? So even in Nigeria, we're mainly a private healthcare seeking behavior. And so people are going towards public-private partnerships. That's really helping. But what I think is, putting the fire under government's belly, so to speak, is that a lot of people are creating these things by themselves, right? So healthcare providers, owned by doctors, led by doctors. And when you don't have the luxury in the States where it's balanced by healthcare insurance, in Nigeria, a lot of people don't have healthcare insurance at all, and they just pay it out of pocket as and when they need it. So I think that competition with people making a lot of money privately and it's not going towards government institutions, I think they're realizing that they need to improve upon that so that, you know, because at the end of the day, money talks, right? So that really is what leads policy, unfortunately. Very cynical aspect, but that's just the reality of the situation. So I think more things that are happening like that means that the government will be, focused on putting that money into the healthcare infrastructure so that they get money from people paying out of pocket rather than somebody going to a private run institution and it doesn't get to them.
That's actually really interesting, and I'm sure there will be a couple of questions in the Q&A. I think now will be a good time. I'm conscious because we have two panelists who are working in genomics at the moment. I'd like to do a bit more of a deep dive into genomics and data and maybe the more health tech aspect. So I have another big question. Maxine, if you could just explain to us what genomics is and why it's so important in the discussion around prevention.
So we were talking about this earlier. So even though two of us work in genomics, I'm certainly quite a genomics skeptic. But maybe that makes me like slightly better at working in the field than I am. So I presume everyone knows what your genes are. The genes encode lots of things in your body, and one of the things that does is it affects your risk for things, it affects your predisposition to things, it affects how you respond to things like drugs. Most genes are not that modifiable within a generation. It can be across different generations, but they're basically the stable thing that moves across generations. I think like the highest level, that's what your genes are. What makes up our health is a kind of cornucopia of different things. You've got probably about 20% is actually the healthcare that you receive. That's the drugs that you take, the tests that you have, the procedures that you experience. About 10% is your genes. And then the remaining is basically divided between things called your social determinants of health. So that's things like where you live, what you sleep, what you eat, who your friends are, what you work on. And then the other bit of it is about kind of the remaining 40% is about your behaviors. So that's kind of how much you act on and behave around all those potential risks that are somewhat stable, or at least vary at a slightly slower rate over time compared to your behaviors. So 10% is not a lot. And so certainly when you're looking at the context of someone's overall health, there's a kind of slightly kind of tropey thing, which is that your postcode matters more than your genetic code, which by and large is true. But there are some kind of specific cases where your genes do really make a very big difference. And that's because, over time we've had particular areas where we focus on certain conditions. So, conditions like dementia have been massively helped by specific genetic understanding in terms of people's risk and what impact that has on your neurophysiology. In some respects, I feel that genomics has had a huge amount of attention over the last 40 years, and we have yet to see the fruits of its labor. I think you probably see that with almost all emergent technologies. If you speak to people who worked in AI, about 40 years ago plus, they'll say, gosh, we've been having the same conversation and yet we still don't see AI in mainstream healthcare or most of our society. And I do think that probably most geneticists will argue that the impact of genomics, certainly in terms of the mainstream healthcare, has been overhyped. But in the UK, we've got a thing called the Genomic Medicine Service, which, unless you've got cancer or rare disease, you might not have heard of, but this is the largest national integrated genetic testing service in the entire world. So if you have a cancer or rare disease, or you have a risk of those in the UK, you will be offered whole genome sequencing, which is in part run by Genomics England. And we don't actually necessarily know whether that's a cost-effective thing to do yet. In reality, probably you could pick up risk in different ways, but without actually starting to integrate this in the health system at scale, we won't necessarily know if it will kind of reveal the fruits of its labor, having had so many years of investment and intention as like the spicy new thing in biotech.
It's interesting you say you're a cynic. Is this because you believe socio-economic factors play a bigger role? And I guess my second question is, how do we use socioeconomic data alongside genomic data? What's this relationship here? Do we have to be careful not to kind of focus our energy more on one side than the other?
So the program that I run at Genomics England is focusing on improving ancestral diversity in data. And unless you work in genetics, you might be like, I don't know what that means. So think of ancestry as a very crude proxy for race and ethnicity. Race and ethnicity are not genetic factors, but they're very correlated. So an ancestry is things like someone being of European heritage or South Asian heritage. A lot of these populations, because of systemic racism, and migration, by and large, sit in the kind of lower socioeconomic groups in the country. Obviously not all, but there is a correlation there. And so these populations don't tend to be as healthy as white people in the UK. And so there's something problematic in certainly the program that we run, where you're going to populations who can't afford to pay their rent, can't afford school meals, are struggling just to exist. And you're saying, hey, we've got this really great new technology. Would you like to give us your sample so we can do some whole genome sequencing? Maybe we'll have a benefit in your health, maybe not. The ask is not massively compelling. And I completely understand that. The benefits of genomics to an individual in that sort of situation is currently not massive. Now, there are some conditions where that's certainly not the case, but I'm just broadly talking about groups here. A good illustration in genetics is a thing called a polygenic score. So a polygenic score is a type of model in all of our sectors and our worlds. I know that we've got not necessarily a health audience here. You've got these predictive models. The big one that gets used in genomics is a thing called a polygenic score, and it's basically your risk for a certain condition or a trait based on your genetics. And the thing I find funny about polygenic scores is they're basically often set up as a univariate model. So they're often like a genetic factor and the outcome being like cardiovascular diseases. Often when you then put polygenic scores in the context of everything else that's happening in someone else's life, if you're able to, say, have additional data because you've surveyed them or you understand other traits they have, the contribution of the genetic factor really, really reduces, and you realize that actually that's not the kind of the lowest hanging fruit for intervention. But unless you actually have data on people's other socioeconomic behaviors and other people's existence, you're not able to make that kind of finding. You're not able to say, actually, this is the relative or absolute impact of genetics on your overall health. And that is not data that obviously we collect in the health system, because almost by default, it's data that sits outside of the healthcare system. It's stuff that's with your education, it's stuff with your food, etc. So one of the kind of things that I was working on before when I was at the Turing was to what extent we could create latent structures of people's health based on non-health data. And that almost exclusively sits in the private sector. So going to kind of Yamisi's point, companies like Google Health, who track our really mundane everyday activities, are in a far better position to tell us about our health compared to others. So there was a kind of pretty staggering stat that ran a survey about, would you be willing to give your data, social media data, for different types of health condition? And unsurprisingly, people were least willing to share their social media data if it was going to be used for sexual health research. But then they consented to have their history then reviewed, and of everyone who potentially had a sexual health scare, gave Google at least 2 data points. So that's things like the opening times of the nearest sexual health clinic, symptoms of certain STDs. And so even though people themselves are not willing to share that data, Google already knows. And this is not just a Google thing. This is any company that collects mundane daily life activity. And so I think if we're trying to build resilient public health systems, for example, we've got to realize where the huge power in terms of the data collection is sitting. And it really, for me, sits in these big tech private companies.
Do you think if people from disadvantaged groups, ethnic minorities, lower socioeconomic backgrounds, had more trust in health institutions, do you think that would change things?
Sure, but there's very little reason, I think, for most, certainly minorities, particularly minority ethnic communities in the UK, to trust government or public sector. We've got countless examples of eugenic programs in genomics. We have countlessly evidence that we are not a trustworthy group of people. And so I think that people's skepticism based on far history and recent history doesn't, I think, give people a lot of faith that they should trust, certainly publicly funded systems. So yeah, it would be great if everyone trusted the NHS or DHSE or government-esque initiatives, but you have to demonstrate you're trustworthy. And I think that there is a huge amount of recent and historical abuse that has happened, and I think that's going to take a very, very long time to demonstrate that that's a thing of the past. And given just the rates of the disproportionate rates in mortality and morbidity around COVID by ethnicity, and then the way that that was dealt with, I think that's been a pretty kind of big nail in the coffin of not helping on the trust agenda.
I completely agree, actually. Yemizi, what I'd like to ask, kind of, what 54 gene is doing, and I'd like to kind of highlight on this idea of the data gap, and what's the consequences of this data gap, and what are you guys doing about it?
Yeah, so like I said before, a very little clinical research is done amongst the African population. So in fact, when we're talking about genomics, less than 2%, right? And then if you're thinking about, from origins for the human species, we originated in Africa. So that already just shows how important that gap is to fill. And then even within that 2%, it's mainly done on African American population. So you already have that massive jump and that genetic gap already. So 54 gene, and point behind the name 54 is that there are 54 countries in Africa. We're trying to, bridge that gap. So talking more in terms of what I do, so I'm less the techie side, more the research side. I lead the research operations team, and we recruit patients/participants into our healthcare projects that we do, and divided between community-based and hospital-based. And then two parts in terms of that recruitment involves collecting biosamples ranging from tissue, blood, saliva into our biobank. So that's where you get part of the data for the whole genome sequencing and things like that. And then also we conduct interviews as well. So then that's when you have the socioeconomic side of it and building up the data there. But there is a bit of like internal to and fro with that, because you are focusing on the biodata, but then talking about how the determinants of your socioeconomic background and even not just healthcare seeking behavior, but behavior in general can affect your healthcare outcomes. So, putting one of my many hats in terms of anthropology, I'm really interested in the research, in the questions that we ask participants, right? So even something as trivial as, how do you cook your food? Do you use gas? Do you use oil? Do you use firewood? Even, what kind of roof do you have? And that kind of thing. Is it thatch? Is it concrete? And that already tells your socioeconomic background. Whereas our geneticists are that like, well, that's not really too relevant in terms of what we're trying to do. So, and aside from that, with the questionnaires that we ask, you want to get all this information, right? Because there's a massive gap. Like I already said, there's no data in general in terms of what people do. Like I think the housing population survey in Nigeria was done like 10 years ago. So I really want to promote that. Whereas a patient who has already waited for about 4 or 5 hours to see their doctor, and yes, wants to take part in a study, doesn't want to be asked questions for an extra hour. Or if you're in the community setting and you're already having to explain collecting samples, and the massive behavioral aspects of that, and people wondering why you're collecting my sample, what are you using it for, and then also to ask them questions. So you have to marry the two to make sure that the data that you're collecting is covering every interest, but also is short enough for a practical setting. So that's what I'm really focused on, especially in operations. So we have a lot of people that are going back to the word innovation. We're doing something that hasn't really been done before, not only in Nigeria, but in the African population. So, and there's a lot of tech that goes into that. So for example, in collecting the information, we use tablets, right? But then they have to have offline capacity because the places that you're going to probably won't have network and things like that. So we're talking to all our techie side of the organization. And then if you have this really fantastic idea, so for example, one thing with collecting biospecimen and the fact that you're going to hospitals, you want to make sure that one participant you've recruited, you haven't recruited elsewhere. So we wanted to use biocapturing, which sounded really great. But then when you think about it practically, it wasn't necessarily going to work because we don't have the technology to cover it everywhere, right? So, it's trying to promote that and, make sure that people are able to notice, and when I say people, I'm talking about government and the decision makers within our society, know this gap and want to help and improve that, right? So, talking something as very basic as electric medical records, like the NHS. It's fantastic. Like I can go anywhere and they have the information from when I was born, right? Whereas you can't have that in Nigeria at all. Like if I go from one clinic next door, I can just give completely different information and there's nobody that's able to combat that. So part of in another organization I was working at, we were trying to improve the awareness of EMR and promoting it through funding, through DFID as it was then and things like that. So that's really in a nutshell, well, big nutshell in terms of what we do. But I think, I'm very, very intrigued with genomics. Like I said earlier, I fell into biotechnology because it wasn't really on my radar at all. But I think it's just amazing how much of this information is unknown and how much of a difference it can make. But as fantastic as it is, and that's similar kind of to what Maxine was saying, is that there is a long timeline from when that information that you have found and this data that you're collecting makes sense in a practical sense. And what I mean by practical sense is really drug discovery. And, that's what, Big Pharma is very, very interested in. So it's trying to speed that up, but in a responsible way, so that, the people that I'm going to in these research poor settings do benefit and see why they, were taking part in this research that we're promoting.
I'm going to ask a bit of a counterfactual question here, but if we did nothing about underrepresentation in genomic data at all, if 54 gene didn't exist, what would the future of health look like? What would this mean for things like health equity? Why is it super important that we do what you're doing?
Yeah, that's a really good question, especially because, like I said, it's very news and clearly we're all doing okay with the things that we're taking. But, how somebody tolerates a specific drug can be very, very different to how another person, even like, looking at us on the panel, we come from very different places and things like that. And, moving on to what we were talking about in terms of non-communicable diseases or chronic diseases, that is very, very important and potentially quite scary if we're not doing the investigations that we are now. So it is very, very important and people are realizing that. So, whenever I talk about what I'm doing, even to somebody that's just not interested in healthcare, as you do, like in a pub and someone says, oh, what do you do? And I say, I work for a genomics company. Like, oh, okay, great. What does that mean? And then I say, okay, talking about if I take this particular medication, it can be very different from how you take that medication. And then they're like, oh, wow, like, that's fantastic. So, what does that mean for cancer? Or I have this, chronic disease, or I know somebody that is suffering from this. So health does affect us all, even though we don't prioritize it. So we need to also make sure that we reflect that and we reflect the society in the clinical research that we do.
Yeah, I just want to add something and build on the point to say that, okay, the work that the MEC is doing is actually fundamental for the future of healthcare, because collecting data, I understand the point of discussing about genomics, but collecting data and having data from people in Africa, low-income setting, is crucial to improve healthcare, to all this movement of preventive care and stuff like that, because if we don't have that data collection part, it will be difficult in the future to be able to really implement all that. But another important point is, in my previous job, I was working in a pharmaceutical company doing research, clinical trial. But when you see, you cannot go to FDA if you are not done a study with US population. It is impossible. You cannot submit a new drug in US. Now China is doing the same kind of stuff. If you want to launch the product, you need to do a study there. In Europe, you need to do a study. It is only when you check the data, when you go the table, it is usually the table one, the description of the population. You have very limited study that have been done in Africa. So this work of collecting data, having some data on people, doing clinical trial in Africa is really, really important for the future of healthcare.
to make it more complicated, so the genetic diversity within Africa is bigger than between Africa and any other country in the world. Yeah. So saying, we've tested drug on an African population should be scarier than if you said this has been tested on a Japanese population, but we're doing it in the UK. But the point I'm making here is that it's kind of like whack-a-mole when you're trying to define what is sufficiently diverse, what is sufficiently representative. Because if you choose one axis, be that ethnicity, age, gender, or whatever it might be, you're instantly going to bias your data. There's no such thing as an unbiased data set. Everything is a sample of a population. And so there's a really interesting problem, which is like, what is representative enough? And you never quite know. So for me, a lot of this is actually how we monitor a lot of these interventions kind of in the wild, like post-marketing surveillance, if you're from the kind of more pharma world. Like there's a study that's kind of the canonical study as to why diversity in genomics matters is one on hypertrophic cardiomyopathy. And effectively, this study just did a subgroup analysis, linked in a little bit of additional data, and basically found that all individuals of African ancestry had their variants identified as pathogenic when they're in fact benign. So what that means is, as a patient, someone said, you've basically got a really big risk for a thing, and it was wrong. And as you can think, that must be so scary as an individual to receive that diagnosis, and that's happening kind of all the time. But if that subgroup analysis hadn't been done, it wouldn't be known that actually there was this kind of discrepancy by ancestry. So I think a lot of this at the moment is just doing as many stratifications as you can by any axes that you think could be potentially viable here. We're not in an infinite resource setting in any situation, but yeah, stratify your data, kids. Stratify your data.
I think that would be a great time to open up questions to the floor. I know we started a bit late, but so I believe, there's microphones around. I think you have to just press the button, right? Yeah. Perfect. First one over here.
Thank you. My name's David Wood. I want to dig more into the genomics question. And I agree that we should be sceptical about some of the naive claims that were made earlier that certain studies of genomics would unleash lots of insight. But what does the panel think about the rather remarkable findings from genomics of super agers? They're people who live like most of us would love to live. They're 95 years old or older and as healthy as most of us in the 60s. And it seems that they don't have a single gene which confers this on them, but they have families of genes which make a difference. What's also interesting is they tend to be in family groups, and they also often have bad lifestyle choices, if I can say that. They smoke and they don't eat vegetables, but still remarkably they're healthy. So have you looked at this? And because it seems that if we could understand what's different about the genomics, and it seems that there's something to do with how the body manages cholesterol, something else to do with how the body manages insulin-like growth factor, and so on, that we should then find possible pharmaceutical interventions to mimic this and help more of us to avoid diseases, possibly live longer. And these people, by the way, typically cost the health service a lot less than most people do. By the time they die, maybe 102 or more, they have cost the health service a lot less than the average person who dies at the age of 82.
So we're very much in the business of cancers and rare diseases. We're in like the curative genomic space. But I think you raise a really interesting point, which is quite a lot of, I find, genomic research is around saying, well, why does this person get sick? And it's not, why are these people so much healthier? Which I do think fundamentally shifts the study design. So I think you probably know a lot more based on your question on this than me, but that is something that I think comes up quite a lot, is why is it always a kind of deficit model that we're trying to kind of bring up? That example you give of, often those people who live the longest seem to have like the most unhealthy habits, I think is just such a good example of the fact that we have this quite myopic view on what is modifiable, what is non-modifiable. And in order to kind of really unlock what's happening to these people, that the depth of phenotyping needs to happen over such a long period, we just don't have. So there's a new study that's gone live called, it's called Our Future Health. It's a 5 million person study. It's it could be, if it hits the numbers, one of the largest studies in the world. And it's basically honestly taking the kitchen sink of all data in your life and following up over your entire life. And it's meant to be one of the biggest longitudinal studies in the world. And it's meant to ask and answer some of these questions, because today we haven't picked up members of the population, follow them over such a long period of time, and phenotype them so extensively using new technologies. So go to your boots and sign up as well, even though you're probably all quite healthy because you're sitting here at the LSE. But we need a real diversity of people. But so sign up to Our Future Health so we can answer some of these questions, and we can all smoke loads, drink loads of whiskey, and yet still live to 120.
So just talking about from a resource poor setting, that is a very interesting question. Like I said, we are starting at the very beginning. So there are a lot of gaps that we're trying to fill. But like, for example, just taking the most recent pandemic with COVID, we all know like how much of a knock it had on society and mortality rates and things like that. Whereas in Nigeria, the most populated country in Africa, and then I live in Lagos, which is second most populated city, so we have about 22 million, and people weren't really dying from COVID as experienced from other places, like for example New York. I have a family member who lives there that was seeing people literally being shuttled, to ambulances, dying and things like that, and we were just not seeing that in Lagos. And in Lagos we were doing all the things that you weren't supposed to, so everybody's congested, nobody is wearing a mask, people who lower middle income didn't even believe in COVID and only thought that it affected, higher income population. You could argue that people who are dying from COVID aren't going to the hospitals, and maybe that's why it's not being reported. But like I said, in terms of the burden, we just were not seeing people die as much. So that is something that's very interesting. And, not necessarily talking about bad healthcare behavior, but, people don't necessarily eat the fruits that they're supposed to because they're more expensive, especially in Nigeria / Lagos. So really bad population and stuff like that. So when you're talking about, for example, we have generators that's really, really bad, and you think it'll be affecting our lungs and stuff like that, but we don't have those kind of illnesses when we're talking about chronic lung diseases, lung cancer, and things like that. So we are asking those questions and building that information. And I'm just always going to go back to the fact that you have to start with the data. You have to start asking these questions so that you can start analyzing and start seeing the trends there before you can even go on to with genomics research and stuff like that.
Thanks. Anybody else? Up the back there, yep.
Hi, my name's Dylan. I'm here studying on a short program at the LSC. I had the opportunity last summer to work at a biotech startup that was integrating AI to investigate glycoproteins and develop kind of new oncology diagnostics through that. So I wanted to just ask the question, what are your thoughts on kind of looking at post-translational data to kind of bridge the gap that's currently in the genomic data?
So can I ask clarification? What do you mean by post-translational gap?
So like, I don't know, looking at epigenetics or looking at like glycosylation or like other kind of like omics like that instead of, looking specifically just at DNA.
This for me is like the origin of my skepticism. So I'm surrounded at Genomics England by people who love lots of different other types of omics, and I'm just like, we can't even get it right with genomics. So I'd like to stick with that one first. I think for my specific program, which is again looking at ancestral diversity, I do think looking more at the epigenome is probably the one that rises to the surface most often as the kind of the area that we should be focusing next in the program. I'm going to sound like a kind of broken record here, but I do think that as the cost of sequencing continues to plummet, Illumina just announced that you can do it for $200 now with a new device. The barrier to access to whole genome sequencing or just radiotyping is like that's not going to be the barrier anymore. It's going to remain things like the secondary data that's appended to it, so that your electronic health record data or your ability to deeply phenotype. And ultimately, our discoveries are only as strong as what we can associate against. So it doesn't really matter what omic you have. You need to be able to have some phenomics or some phenotypes to be able to associate against, and that will remain the data gap as far as I'm concerned. So So I'm slightly skirting your answer because I don't have lots of opinions about other omics, because I think that if we don't get the phenomics bit right, you can omic everything else, and that's going to be the rate limiting factor as far as I'm concerned.
Would you mind just briefly defining what phenomics means for us?
Sorry. I was about to be like, you worked at a biotech, what are you doing in the LSE now? I definitely was here when I did my health economics master's being like, I think done the wrong masters. I'm going to go and do a machine learning PhD instead. In the world of omics, phenomics isn't a real thing really, but your phenotype are traits that you can observe and measure. So that could be your blood pressure, your height, your weight, your skin color, your hair color. That's a phenotype. And so people who work in omics like to say that the phenotype is just another type of omics, so they've called it phenomics. But it's not really an omics. But that's the origin of that word. So your phenotype is just what you look like and what you can measure and see. But there's lots of other omics that underpin. It's not just genomics. There's proteomics. There's all sorts of other omics that all in some way contribute.
Thanks. Okay. Yes, at the front here.
Hi, I'm Peter West. Maxine was saying we shouldn't trust government agencies with our health data because they tend to abuse them. For a start, is that deliberate abuse or accidental misuse that you're talking about? And secondly, should we trust what Google Health is going to do with our data or other non-government agencies more than that?
Very, very good question. So, and I'll caveat this with, so I used to sit on the DeepMind Health Independent Review Board, so just up the road from here, but DeepMind, for context, was a company acquired by Google to do lots of fancy AI, and they created a kind of health division, and as part of that, they brought in a bunch of people who were independent reviewers, so we didn't sign any NDAs, and we were there to kind of ethically audit the company, which for an alphabet company is pretty kind of radical. So I have a lot of opinions about transparency in big corporates, particularly someone in the alphabet family. I think that's a really, really tricky, interesting question about whether it's deliberate or accidental. I would say that in the past it was deliberate. So if we're going to go really far back, let's say that the creation of even just things like race as a term was a process of taxonomy that was created in order to justify colonial expansion and slavery. If we're going back 100 years, that I would say is quite a deliberate one. If we go that to more near term, I would say that it's not so much deliberate, but it's a priority difference. So I think it goes back to we have to make decisions about whose equity we're going to improve the most, and in every point we make a decision, someone is going to lose out. So even us as a program, we had to decide where we were going to prioritize our 25 million of our resources within our program. And we made the decision about who was underrepresented for us. We decided that it was going to be a mix of people that to date have been understudied, from a global context are underrepresented, and if we were to create an intervention, that would have the single biggest cost savings to the health service. And that's a huge set of value judgments we've just put onto that decision, but inevitably a whole group of people would have missed out. So for example, for the traveller community, huge underrepresented in genomics, have very, very interesting genetic conditions. They have been under-resourced. The South Asian community are not included in our criteria. So that's a kind of deliberate, but it's knowingly deliberate. And I think probably just getting better at doing kind of looking at the consequences and the inadvertent consequences of what we're doing is really important. So we, in fact, work with two research groups to run reviews on unintended consequences of diversification efforts, because the road to hell is paved with good intention is kind of my punchline for that. That's the kind of the first question. The second one is that, so I used to work in analysing NHS data. I opted out of my data being shared because I saw how crappy we all as analysts behaved around that data. The systems we use are rubbish. It's really cumbersome. People screenshot stuff. That's how data analysis happens, unfortunately. And I think that private companies particularly, are held to a much higher standard, have a much higher degree of professionalism, take security much, much more seriously than I would say like the rogue academic sector. So I actually would trust private companies more with my data. Partly because I think that they are more explicit and more transparent about what is done with their data than other either research groups or public sector groups, who I think either deliberately obfuscate or are lack the degree of professionalism that maybe the public sector does. So that would be my take, but I think you probably will have slightly different opinions.
Not necessarily different, but just in terms of like putting it back into the context where I'm coming from. So You know, with genomics and even like research in general, a lot of like policies and stuff are playing catch up. So it's really taking the onus on like the private organizations that are bringing in the research projects, right? So sometimes, for example, when I'm talking about drug discovery and big pharma, you already have, you know, money being the main factor into why they're looking at specific groups and what questions they're asking and why they're asking those questions. Whereas, you know, with genomics research and when we're talking about like phenotypic data, socioeconomic data, and things like that, it's quite retrospective. You don't really know what you're looking for yet, but you want to collect this data so that when you do have an idea and you have done the analysis, then you have things to back it up, right? So when you're recruiting a patient, it's really, really important, informed consent. So even having something as standard as like an opt-out option we're not really there yet. So when we're approaching these patients in outpatient clinical settings, and we have to go through informed consent and we have to explain what we're doing and why we're doing it. And then the language we use is very, very important, because you don't want a situation where first of all, the participant may not even understand what they're doing. So we have to make sure that there's a translator there. It's even in the language that they speak and things like that. If they can't read or write, you have that noted down on the informed consent form. They can take the copy home with them if they can read it and do with it what they like, but make sure that they're protected. And that's really like, you know, the onus on us, and that there are ethical boards and stuff like that. But in terms of the genomics aspect, the language isn't there yet. So we prioritize to make sure that it is fine on international standards. But unfortunately, other people may not consider that a priority. So I think that is really, really important question to ask and make sure to promote as well, because a lot of people ignore the ethical side of it when you're talking about collecting data.
My assumption is always that if you're giving data to a private company unknowingly or knowingly, like they exist to maximize shareholder value, and I'm so clear that that's the outcome, that I understand the contract I'm engaging with. But if it's public sector research, it's ostensibly for, it could be arguably ostensibly for public benefit. But I'm a white tertiary educated woman from Oxford. Like, the public benefit is always going to be in my favour, and I can say that. Therefore, I probably would be more trusting of government activities and initiatives. But if I didn't have the background that I had, then you know what public benefit is. You could say, well, at the moment, I don't sit within the public benefit in terms of my experience of living, say, in Britain. So yeah, I think the fact that every time I'm having my data processed by a private company, knowingly or unknowingly, at least I'm very clear about what the outcome they're going for is.
Any other questions? And there was one more from someone. No? I think we're doing really well. We're doing perfectly on timing. If there's no other questions, I think we'll wrap up there. Thank you very much to our speakers. That was really, really interesting. Yeah.